in the chat, we won't be able to see. So I think you should think of the chat as a way of communicating between yourselves. So for example, if you have a comment that you would like to add to the conversation, please feel free to put that in the chat. We will not be able to see the questions that are put in the chat. So what we're asking instead is at the appropriate time, which probably will be generally at the end of the seminar, please do feel free just to unmute. You can use the raise hand function so that each of you know when you'll be asking a question. But please just feel free to unmute and ask your question at that time. We'll probably come directly to you and say, you know, do any of you have questions? So again, please don't put your questions in the chat box. All right. So next up is Dr. Nancy Schiller, who will be giving the introduction to the three speakers for today.
Ruby. So I am so excited about today. For those of you who don't know me, I've been back in Epi for 5 years, but I spent 14 years at the HealthPartners Institute. And so to have my colleagues here today, even honestly, I forgot we're going to be here, is just so exciting. And I'm so excited to introduce you all on the Zoom and in the room who aren't familiar with the great, amazing work that HealthPartners Institute is doing to really get to know about that. So specifically today, and I feel like it's been a little moved, but Dr. Kristin Palmsten, Dr. Gabi Vasquez, and on our screen, Dr. Malini De Silva are going to be talking to you about their maternal child health work at the Institute. And Kristin actually was coming, like we were ships passing in the night. She was coming to HealthPartners as an investigator when I was leaving, and she trained as an epidemiologist at Harvard and come from San Diego. And then Gabi completed her PhD in this very division. And then Malini is also an epidemiologist, and Malini is a pediatrician by training, but has been at HealthPartners, has worked at the CDC, Malini, I don't even know all the different things that you've done, but together, they're an amazing team and only represent like the tip of the iceberg, because some of the other parts of the iceberg are in the back of the room. I'm gonna stop talking to give them time.
Thank you, Nancy, for that warm introduction. We're really excited to be here, and thank you very much for the invitation to come. So I'm just going to give a quick overview on our new Center for Pregnancy and Child Health Research, and then Malini will be giving a research talk on identifying disparities in HPV vaccination coverage by language group. And then Gabi will be talking about COVID vaccine surveillance, safety, and early pregnancy. So for some background, HealthPartners is the largest consumer-governed nonprofit healthcare organization in the country, and the headquarters are in Bloomington, so really close by. HealthPartners Health Insurance has the plan has 1.8 million medical and dental plan members. And HealthPartners Care Group is based in Minnesota and Western Wisconsin, and it's a multi-specialty group practice of more than 1,800 physicians with 8 hospitals and 55 primary care clinics and 24 dental clinics serving 1.2 million patients. And importantly, for our pregnancy research, there are about 12,000 prenatal care patients per year. So not only is there a health insurance plan and a care group within HealthPartners, there's also a research institute. So it's a nonprofit organization dedicated to conducting high quality public domain health research. And we collaborate with other academic and research organizations like the University of Minnesota. We participate in research networks, including Vaccine Safety Data Link and the Healthcare Systems Research Network. We have many areas of research going on at the Institute, including neurosciences, critical care, oral health, occupational health, chronic disease, health economics, and of course, pregnancy and child health. Our project funding is primarily from federal sources, and research investigators break grants and lead projects. And we have wonderful internal teams that support the projects, including a research subject protection program, a statistics and methodology group, the Center for Evaluation and Survey Research, and software engineering and research informatics groups, as well as grant development specialists. So we already heard about some of the connections we already have with this division, and we're really looking to just strengthen those ties further by kicking off our center and being here today. So we have a history of several successful research projects funded by the National Institute of Health, including the milk studies, the BestFit, the network studies, and Calm study. And we've been lucky to have student collaborations from the division for research projects. And we are also really grateful that we've been able to recruit many division alumni to the Institute. So why are we starting a new center? There's actually been a long history at HealthPartners Institute of grant funding and projects and expertise in pregnancy and child health research. Now we're looking to take it to the next level and really build our external collaborations with the center. So we had a budget approved in January this year for the inaugural planning year, and then we hit the ground running and formed the steering committee this spring, and we are officially launching publicly this fall. So the center's mission is to improve care, health, and well-being of mothers, children, and families through the life course. And we aim to fulfill our mission through evaluation and development of interventions focused on pregnancy and child health. Our center will engage in work focused on health equity. We collaborate with HealthPartners Care Group, HealthPartners Insurance Plan, and community partners to fulfill our mission. This is a schematic of the main focus areas of the center. So we have a lot of externally funded research going on, and we're just looking to expand our research through collaborations and additional grant funding. And we intend to continue to engage with health partners, internal partners. We will engage with the health plan to inform plan-based initiatives and programs and contribute to the learning health system for promoting health before and during pregnancy and during childhood and beyond. Also, we want to be a resource for health partners clinicians and help support clinician-initiated research. And for education, I'll be talking about this, but we're having our first annual research symposium in October, so I'll mention the details later. Also, for community partnerships, we want to connect our research with local communities and understand research priorities in the community, and also disseminate findings within the community. And really importantly, we want to help develop a diverse maternal child health research workforce locally and expand our team by attracting new talent to join us. And I'll talk later about internship opportunities. So this is the core team. Malini and I are co-directors within the center, Elizabeth Seberg, and I think everyone on these slides is sitting in the back. I'll meet and greet each other afterwards. So Elizabeth Seberg is our project manager, Mallory Hall is our lead administrative assistant, and Gabby Vasquez-Benitez is a senior investigator and statistician. Agochi Uka joined us this summer, so we're really thrilled to have her. She's an assistant research investigator. And Elise Carbanda is executive director of research and pediatrician and senior investigator at the Institute. We also have some wonderful internal collaborators at the Institute, including Jeanette Frigenfuss and Megan JK, who lead our Center for Survey and Evaluation Research, and also Rebecca Rossum and Stephanie Hooker, who are investigators in mental health research. This is an overview of our center structure. So we have a steering committee with external and internal stakeholders. So steering committee members include community organization representatives, governmental public health representatives, and research collaborators. And we also have external students who are interns. And internally, we work with the health plan, the care group, and then institute partners as well. So I just wanted to provide a few examples of the current work that we do, just kind of give a sampling of the type of studies that we run. So we have a number of CDC contracts, including the Minnesota Center of Excellence in Newcomer Health, which focuses on immigrant and refugee health issues, including COVID-19 vaccination uptake by language group and health concerns related to the recent influx of Afghan and Ukrainian immigrants. Also Vision, which is a network evaluating COVID-19 and influenza vaccine effectiveness, including in pediatric and pregnant populations. The Vaccine Safety Data Link, or VSD, is a CDC network evaluating safety of vaccines. And the HealthPartners Group is leading most of the VSD COVID-19 vaccine safety studies in pregnant populations. And these include evaluating the risks of preterm birth, spontaneous abortion, stillbirth, and infant outcomes, including major structural birth defects and infant growth and development. We have a number of studies funded by the National Institutes of Health, including Ellen Demorat's maternal obesity, milk composition, and infant growth study, which we're recruiting health partners patients for. Also, the Managing Our Mood study, which is a study assessing treatment initiation for new episodes of depression during pregnancy, and we're partnering with other health systems across the country, including the Kaisers, and we are using our health system EHR data and health insurance claims data to do a retrospective study. And we have the Mindful Balance for Mom study, which is a implementation trial of a mindfulness-based cognitive therapy program that's delivered entirely online for pregnant people. And then we have a recently funded study of maternal COVID-19 vaccination and lactation outcomes. We also have several industry contracts, including a study on Tdap vaccination during pregnancy and postpartum and lactation-related outcomes. And we're a part of the Innovation in Medical Evidence and Development Surveillance Program, which is a part of which uses the Sentinel Common Data Model to conduct post-marketing studies of medication safety, including during pregnancy. And then we have some internally funded projects, including 18Q, which is a pilot study to evaluate feasibility, patient preferences, detection of risk behaviors, and using an electronic teen questionnaire in adolescents. And just a plug for our research symposium that's going to take place on October 18th from 11:30 to 1. And this is our first research symposium, but we're planning to hold one each fall. This will be a hybrid event at the Masonic Institute for the Developing Brain, and you can register online for it. We'll be sure to circulate this announcement with the division. And we're really excited to welcome Dr. Jamie Slaughter-Acey to give our keynote talk. We have internship opportunities. So Hibo Mohammed is our center intern for the fall, and she's working on a validation study comparing infant breastfeeding status to routine healthcare clinic visits with information collected during study visits. And we'll have more opportunities planned for 2023. And we'll be sure to circulate posting with the division. And finally, I'll just wrap up by reiterating that we're welcoming new collaborations, and Bochi Upka is the point of contact for exploring potential research collaborations, and her email address is up here. And with that, I think I will hand it over to Malini. Malini, are you ready?
Yeah, can you hear me?
Yeah, would you like me to advance your slides, I think?
Yes, I don't know how to take control of it right now. Okay, well, good morning. I wish I could be there in person, but luckily this hybrid option was already set up for us. So I'm going to be presenting a study we were able to complete with funding through our new Pregnancy and Research Center. So we're excited that the center is already starting to fund projects and let us do some work that we don't have other funding for. Next slide. Okay, so human papillomavirus or HPV vaccines are effective at preventing HPV attributable cancers, including cervical and oropharyngeal. HPV vaccines are routinely recommended for 11 to 12-year-old adolescents, and HPV vaccine series can be started as early as 9 years. Disparities in HPV vaccination between race and ethnic groups have been reported, but are inconsistent among age groups. Some studies have shown lower uptake in non-Hispanic, Black, and Asian adult populations compared to non-Hispanic white populations. However, these same disparities are often reversed in studies evaluating adolescent HPV uptake. Disparities in HPV vaccination may also be present within racial and ethnic groups. And one measure that has frequently been evaluated is nativity, or whether there are differences based on a patient's country of birth within these racial and ethnic categories. Language preference may be another surrogate measure to account for heterogeneity among racial and ethnic subgroups, and may be used to identify racial and ethnic disparities that are not evident across broad racial categories. Next slide. So the objective of our study was to examine disparities in HPV vaccination coverage by language group and nativity among a population of adolescents receiving health care. Next slide. So our study and population included HealthPartners patients aged 9 to 21 years as of June 30th of this year, with at least one care encounter in the previous 3 years in a HealthPartners primary care department, which we define as pediatrics, med-peds, family medicine, or OB-GYN. And we obtained HPV vaccine administration dates either from our electronic health record or MIC, which is the Minnesota Immunization Information Connection. It's the state's immunization information registry. We evaluated 2 HPV coverage measures for adolescents that turned either 13 or 18 years during our study time period, so 2017 through 2021. The first measure was HPV uptake, which we defined as having 1 or more HPV vaccine. And the second measure was HPV vaccine series completion, which was defined based on the patient's age and the age of their first dose. So for 13-year-olds, that meant having 2 doses completed by their 13th birthday, and for 18-year-olds having who had their first HPV dose under 15 years, 2 doses, or if they started the HPV series after they were 15-year-olds, then they needed 3 doses for completion of the series. Next slide. We compared HPV coverage for the following characteristics. We looked at trends in coverage. So the calendar year when adolescents turn 13 years or 18 years, language preference, whether the patient in the electronic health record noted that they preferred English or other non-English language within these racial and ethnic categories. And for adolescents turning 13 years, we looked at HPV vaccination uptake among selected language groups that included more than 100 subjects. We also looked at the difference in HPV vaccination uptake for race and ethnicity, English preference, public insurance, and sex. And all the comparisons were adjusted for sex, calendar year, and public insurance based on known kind of differences in uptake for these different demographic variables, and calendar year, I guess, time. So this table shows the characteristics of the study population. There were just over 63,000 13-year-olds and 59,000 18-year-olds that we included. The largest racial and ethnic group was non-Hispanic white, followed by non-Hispanic Black or African American. Females made up half of the study population for 13-year-olds and slightly more than half of the 18-year-old cohort. There was a larger percentage of individuals with a non-English language preference for the 13-year-olds, so 7.7% versus 3.6% in the 18-year-old group, and interpreter needs were higher in the 13-year age group as well. Approximately 42% of the 13-year-olds and 35% of the 18-year-olds had public insurance. Next slide. So this table shows HPV vaccine coverage at age 13 years or 18 years by calendar year and race ethnicity. I've highlighted the calendar years to note that coverage increased annually for the 13-year-olds from 2017 through 2020, when the coverage kind of plateaued for that age group. And for the 18-year-olds, the increasing percentage of coverage continued throughout the study time period. Overall, patients identifying as non-Hispanic, Asian, Hispanic, and multiple race had higher coverage than other racial groups. Next slide. So this slide shows HPV vaccination coverage at 13 or 18 years by sex, at birth, language preference, nativity, need for interpreter, and insurance status. Overall, females had slightly higher coverage than males. And for the other demographics listed, there was little difference in coverage for the 13-year-olds, but for the 18-year-olds, you can see that English preference, being born in the United States, and lack of interpreter, those categories had higher coverage than individuals who had a non-English language preference, were not born in the United States, or needed an interpreter for their visit. Next slide. This slide shows HPV coverage with at least one dose and completion of the HPV series for both the 13 and 18-year-olds. The hashed lines show age 13 and solid lines show age 18. So coverage for both uptake and series completion increased annually for both groups, like you saw in the previous table, until 2020 when it plateaued for the 13-year age group and continued to increase for the 18-year-old. Next slide. These two figures show HPV vaccination coverage at age 13 years by racial group, stratified by whether a patient has English or a different language listed as their preferred language. This shows both higher uptake and completion of the HPV series in Asian and Hispanic racial ethnic groups who have a non-English language preference than among those who have English listed as their language preference. Next slide. And these two figures show HPV vaccination coverage at age 18 years, again, by racial group stratified by their language preference. And this shows both higher uptake and completion of the HPV series in all racial groups with English language preference than among those who have a non-English language listed as their language preference. Next slide. We looked more closely at HPV vaccine uptake at age 13 years by language group. And as I mentioned in the message, each group had to have at least 100 patients included in the group. And because of low numbers, some of the language groups, we combined languages to reach this minimum number. The combined language groups are listed in the footnotes of this slide. This shows that there's certain language groups with higher HPV vaccine uptake than those with English language preference, specifically Spanish, the Korean, Burmese, and the Vietnamese language groups had higher coverage than those with English language preference, while groups with lower uptake than the English language preference included Somali, Ethiopian, which includes languages such as Amharic, Anuak, Oromo, and Tigrinya, and Eastern European language groups. Next slide. And this figure shows the difference in coverage estimates for HPV vaccine uptake at age 13 years for race, ethnicity, language preference, sex, and insurance status. And the reference group for each variable category is listed in the highlighted rows. So compared with white 13-year-olds, there's higher uptake among 13-year-olds identifying as Asian, Hispanic, or multiple race. For those with English language preference, they had higher uptake than those with non-English language preference overall, although as you saw on the slide before, there was some difference among the different language groups. Females had higher uptake than males, and those with public insurance had lower uptake than those with other types of insurance, which is somewhat different than what we've seen in some of the national immunization surveys. Next slide. So our results show that HPV vaccine coverage, both uptake and series completion for the 13-year-olds increased annually and then plateaued in 2020. And for the 18-year-olds continued to increase annually during the entire period. The coverage varied across race and ethnicity and preferred language groups. As I discussed for the 13-year-olds compared with English, coverage was higher in Spanish, Korean, Burmese, and Vietnamese, and compared with English, coverage was lower in Somali, Ethiopian, and Eastern European language groups. The multivariable model showed the largest difference in coverage by race and ethnicity. And race and ethnicity disparities hide differences within English and non-English preference. Next slide. A few limitations of this work. So we did combine those language groups due to small sample size, but this may result in individual language group differences being hidden as well. Second, language that was recorded in the electronic health record may represent either the patient or their caregiver's preferred language. And I think this may be particularly apparent with the 18-year-olds, that once a patient turns 18, the preferred language may switch to the patient's language, whereas for the 13-year-olds, it may be more reflective of the parent or guardian's preferred language. Third, our sample is limited to patients receiving care in the health system, so vaccination coverage may be lower in other populations. And finally, disruptions to care during the COVID pandemic may have impacted coverage, especially for those 13-year-olds during 2020 and 21. Next slide. As far as conclusions, I think that standardized routine collection and reporting of language preference in healthcare data is imperative for improved patient-provider communication and in order to identify disparities in health outcomes that may not be identified using broader demographic categories such as race and ethnicity. Certain populations need culturally specific engagement strategies to improve their HPV vaccine uptake. And further work is needed to understand HPV vaccination barriers and develop culturally appropriate educational messages in patient and caregiver preferred languages. And we hope that with additional funding for the center, we'll be able to do some focus groups or additional work in this area, specifically targeting some of those language groups with lower uptake. I think, are we saving questions till the end? Oh, I can't hear you. You're muted. Sorry.
Yes, I think we're planning to save questions for the end.
If there's any short clarification questions, so we can do that right now. Okay, then Gabby's up next. Okay, Colleen.
Hello, everybody, and I'm so glad to be back. This place has not had it, not been it. I am here. I was here at so I'm going to give you an example of some of our work, and before showing the work, I just want to say why this is important, and it's important to me. One is an example for the work we do in the Pregnancy and Child Health Center and the focus we have, but also shows the way we work in a network of institutions like us, that we put the data together, and the advantage of having so much data. So if you're a student and want to use big data, this is the place to do it. So that's my message on what I'm saying. So the work that I'm presenting right now is in review at AJA. So I'm very excited because we got the news yesterday. So we're very excited. But the results of this work has been already published in JAMA by Oscar Banda, who's here. And this has been a very important work because it has informed policy on vaccine and making women feel safe to be vaccinated. So that's a very important work. So that's another important thing of our work, that we are able to inform practice. So this is an amazing opportunity. Okay, and so this is the results that we got. We had no association, so that was good. So we were like, okay, let's publish this. But when we started doing the analysis at the beginning, because this was a surveillance, so every month we got new data, we saw our data, we presented internally, we presented in to the vaccine fast.
It's a work group. It's so for the full advisory committee on immunization practices, there's a special work group just to study the safety of to review safety of COVID vaccine. And they've been meeting weekly since like the start of the vaccine program. So every month we're presenting to this group that is also are on the main ACIP, the one that are in the news and making the vaccine recommendations.
But we didn't see any problem on the vaccine. It was a protective effect, but that's always also problematic because people say, oh yeah, let's say that it's protective. Everybody should get the vaccine because then you would reduce abortions, but that's also problematic when it's a biased result. So then we said, okay, now that we got more data and there was no association, let's see what were the factors contributing to this association that we saw earlier. So this is that's what brought us to do this second analysis as a secondary analysis. And so we did not have the data from the full network data, but we had the data from our side. So we did the analysis and looking at, okay, did we choose the exposure window correctly, or maybe it was too short? When we designed it, I said, oh, let's use the last date of the period. And then I said, I maybe choose the wrong date. So we changed that to see if it was a big difference. And then because we did a surveillance, we thought that a case control study would be easier to start and follow it. But then we said, okay, now we have more data, and we changed the data structure to a cohort design, and that was done really nicely by another EP here, alumni, Jacob Hapala, and he moved around the data. I don't know how he did it, and he did a cohort design, and we used the data to do the analysis. So this is the network that we're using, the vaccine safety data link. If you see, there are 9 centers, and one of them don't contribute data, so this is an 8 data analysis. All the sites that we're working with do the type of work we do on the vaccine, but also on cardiovascular and many other topics. So these are really good partners to work with. So where does our data comes? It comes from, well, we identified pregnancies using some albums. This is very important. Before, we were not able to do this type of analysis in real time because we needed an algorithm that identified every week the pregnancy. So that's a big step for us to have. And our group from Northwestern in Oregon was able to modify the algorithm so it could be done in near real time. We got our COVID vaccines mostly from the EHR, but in most of the centers, they supplement their data with their immunization systems. Claims and everywhere, every data source that we can have, we use them and clean them, and there's a lot of work there. And so the study period, we have eight sites, and the study period runs from December 15th when the vaccine launched, the rollout of the vaccine program, to June 28th. And in the secondary analysis, where we only use our site, we extended the period until August 23. We did several data extractions, and I'm presenting data of the July 8th and the August 3, that is for the site only analysis. So our study design was case control. The pregnancies were between 6 and 19 weeks gestation, and we used 4 weeks surveillance periods to identify the abortions and to identify the ongoing pregnancies, which were the controls. So each ongoing pregnancy was assigned to one surveillance period. So an ongoing pregnancy that reached 19 weeks could have been observed in more than one period. And some SABs could have been, if they were related SABs, they could be contributing data to more than one period. The exposures was in 28 days prior to the SAB or the index date. And as I said, the index date assigned was aside to the last day of the 4-week surveillance period. This is a diagram of how we identified our ongoing pregnancies and RSABs. As you see, the lines are not well aligned because that's how we look for the data. They're not well aligned. People say, well, but shouldn't they be in the same day? Well, we can't. One, we don't have exact data. These are approximate data. So the LNP, the last menstrual period, or the date of the SAB are really approximate. So that is one problem. The other problem is that we needed a program that was not one-to-one match, because that would not have been feasible for a surveillance analysis doing it this every month. So that's how our design was selected. So we stratified the data by age strata, race, ethnicity, number of prenatal care visits, and gestational age, and the size. And to analyze the data and the association, we use our GDE model with binomial distribution and logic link and a compound symmetry for the covariance structures, because we have multiple records per pregnancy. And we included all the covariates, the strata variables as inputs. In the secondary analysis, when we look at the design choices, we moved from 28 days to 42 days. We selected the days by week because that was our design, and it would have been very difficult. The study periods, we moved them from 4 weeks to 6 weeks to align with the windows to look for the COVID-19 vaccination. And we moved the last date to the midpoint of the surveillance as the index date. And then we changed the study design to a cohort and analyzed it with time-dependent covariate Cox model. So I'm not gonna go through the characteristics, but our cohort is huge, thanks to putting together all the data, network data partners. So our sample size of all pregnancies is more than 100,000 women, and the vaccines in this time period is around 14%. So we have seen that during pregnancies it goes around 22%, but remember, these are only until 19 weeks. And most important, the vaccination, since the rollout, there were very few people getting vaccinated at the beginning, and the people getting vaccinated were very different. So this is prone to bias, or could be prone to bias. So the peak of vaccination was in April. So in our study was in period March and April. And so our period was period 4, where we reached 4,247 women. And if you see the characteristics of the women getting vaccinated, these are women that got the vaccine, shifted a lot. So the distribution is very different. So younger women were not getting vaccinated early in the rollout, and then it increased over time. Then the other characteristics that changed a lot was the race ethnicity. So for example, Hispanic had a very low rate of vaccination, but increased. The proportion of women in the sample started in 18% and moved to 35% for Hispanic, and Black, even low all the time, moved from 3% to 6 to 7%. And the other characteristics really didn't change so much. I'm going to talk about them. But our association, every time I presented the data to the group, my numbers change. Something is wrong. Maybe we're doing something different. I promise I'm not doing anything with the same program, but the numbers are changing. So it changed from data structure. So if you see the just selecting one period. When the first time we did the analysis, our association was 0.78, but then we waited and we got the next extraction, and now was 0.72. And then when we published the paper, data association was 0.66, and so the data was moving. What is the data moving? The data is moving by identifying the abortions because you have more information, so the EHR has more information, so the algorithm can work better. The vaccinations, some vaccinations come late. And so, for example, AJA asked me, why did the association take? It's just so difficult because there were so many moving parts that were changing. So, but never show an association. And then when we accumulated more data, the association tended to be null, while at the beginning was protected. So at the beginning, we had an association of 0.66 reduction, so protective effect. And then when we got the data, our association was null with odds ratio of 1.02 from 0.96 to 1.08. So we changed some assumptions, and so when we did the cohort design, the association was one thing to say. When we changed the assumptions, the cohort is not, the data is, the study population is not exactly the same. Our numbers changed because not everybody can be followed the same way, so our numbers change. So some of the difference between the assumptions is that we're not using this exactly the same number of people. So but our association 1.97, so close to the null. And when we were working with the 4-week periods, our association was 0.82. When we were using the midpoint, our association was a little higher, 0.85. My thinking, they're really not different, but I think it contributes when we are looking at the vaccines, when our higher rates of vaccination, we might pick more if we move to the midpoint, that if we put it later. And if we move to the 6 weeks period, so we can look at instead of 28, 42 days window, our association was lower. And that was consistent with another study done in Denmark by, so it makes sense. Our data is aligned with other studies that we have seen. So we plotted to see the trends. This is with the single site study. We are plotting the odds ratio, and we see that the odds ratio based on the different design features are a little bit different, but they're not statistically different or clinically different. But the most important is that yes, we see an increase in the odds ratio, plateauing to a not null at the end of the period after no more when vaccination did not increase. So what did we find with this analysis? That the biggest factor that affected was the timing of the surveillance. And delays in the data could affect the association. The results were robust by design choices, which is good. So even that we chose the last day and not the midpoint, it was okay, did not change much. I always think that the cohort design has proven to bias. I don't have anything to support that, but I always think that cohort are better, it's more robust, and we can replicate the analysis in real time. So these exercises inform us some of little changes that we did for our current study that we're looking at boosters and maybe later to the bivalent version of the COVID-19 vaccination. So, but there are huge limitations. This is just an exercise of surveillance. Our spontaneous abortions are not child confirmed. We have done child confirmation for other studies, and it's not great. So, and we are not able to adjust for potential confounders. And people say, well, why don't you add them? Well, because this was a surveillance, we choose strategically the least amount of variables which we thought were the most important. And we don't know which is the optimal exposure. What are the strengths of our study? We established a multi-site vaccine safety surveillance, and the way the data was transferred to us was very like summary data. So that's part of the idea of a surveillance exercise. I don't have anything else, but just thanks everybody. Well, from the BSD team and all the people that work in the project, and then thank you here for the presentation for Kristin. Sure.
We have time for questions. Either about the center.
I give you stuff like for thanks.
Well, Kristin, thank you, everyone, for your presentations. I have a question about the center itself. So this is a Center for Maternal and Child Health. And I'm wondering how you're defining these and how broadly you're looking at things. So for example, is fertility within the scope of the center? Are male partners and fathers a part of the center's research mission?
Yeah, thanks for asking.
And do we unmute or what is the best strategy?
We're unmuted.
I don't know what. Who's saying what?
Oh, well, hey, if you want to do that.
I'm muted now.
So regarding the population, so we actually, when we originally were calling ourselves Maternal and Child Health Center, and we realized that like that's been traditionally the name for the type of research we do, but that wasn't the most inclusive term, and we heard that from our steering committee as well. So question came up right away. Well, how do you draw fathers or other partners into your research if you know the name is Center for Maternal and Child Health? So anyway, we our name evolved, and now it's Pregnancy and Child Health Research Center, and I think we have interest in pregnancy prevention and fertility, so beyond pregnancy as well, and then thinking about childhood and adolescent health. And is there anything else we got me involved there?
No, I just remember the discussion of should we include reproduction or should we include other words in the title of the center, and it was just too much.
Yeah, and I'm research that we do a lot of postpartum health work as well, and how do we fit that in? So this was the name that we landed on. It was kind of unsatisfying because it didn't capture everything that we want to do or that we currently do.
Yeah, I would just say the other thing is, as we're just starting and launching, to try to focus on where we have the most expertise. And I mean, we just hired Ugochi, so happy to have her. So with each new hire and each new addition, our expertise grows, but we don't want to overextend with a brand new center. We want to focus on where we have our strengths.
Yeah, I'm just curious to hear you talk about what you think the strengths, I mean, not only of your team, but of the data. Like, are there sort of big questions that are sitting there that you all and your team, well, the data are uniquely positioned to answer, just to help us start to think about ways that our students and our faculty could start to plug in with your center?
Yeah, so I'm a pharmacoepidemiologist and perinatal epidemiologist. So I love the big data. I mean, that's one of the reasons why I came here. And it wasn't just like healthcare claims data, which I work with for my dissertation, but it was also the EHR and then the overlap between them and we can validate things. And So one thing that I've been working with lately is we collect information on breastfeeding status routinely at each well child visit up to 24 months of age. So that's something that's unique at HealthPartners and a few other healthcare systems that we're collaborating with on some projects. Is that the data aren't just put in notes at the well child visit, they're actually put into flow sheets that are standardized and can be extracted really easily by our programmers. So anyways, that's one area of interest, and we're working to validate that with data from Alan Demrat's milk studies and compare that. And then some survey data that we have as well. So there's just sort of opportunities like that. And we are working with our health care group leaders and to understand, like, you know, if we have a question of like something, what happens in the well child visit, or what happens at the first prenatal care visit, we know who to ask and have a good sense. And there's standardized things that happen at each of those types of visits. So I think that's really neat that we can ask people and find out and do chart reviews to understand the data better and how to best pull it, and understand, I think, also the limitations and the biases and where we can try to overcome those. Gabby, did anyone else want to comment on?
I could say, we have. We have big data, and we have really small data, because when we go and now look at pregnancy, or we look at birth defect, now we have 10 birth defects. I mean, it depends on your problem. So that's why we partner so much with other big centers. So Kristin now has a network for the MOM project and for the COVID lactation and the TDAP lactation. So that's so important that even that with our huge data, it gets small when we ask some of the questions that we have. But we have the advantage of knowing how to work with the data, and that is so important for the students, because it's not only knowing how to make the questions, but how digging into the data. And so I always think that the experience of working in our internship with us is it provides a great platform for whatever you go.
I think I'll just add also, along with all the healthcare data that's there, the EHR data, the claims data, we also have an amazing center for evaluation and survey research. So maybe Jeanette or Megan want to talk about the services there and how they integrate with our research.
Yeah, if you want to come and use the microphone, so
These are also tabletop microphones.
Thanks for the opportunity. Jeanette Ziggenfuss and my colleague Megan and Martin are both part of the center as well. And within the center, we have a team of folks that think about survey design and data collection. That's what we love to do. And so we help teams design surveys, minimize bias, and then have a group of team that is also on the phone, calling folks, conducting surveys. We do web, paper, and phone surveys. And because we have this great team of people that are reaching out to folks for surveys, we also do a lot of study recruitment. We have a great team. We represent multiple languages across our team. And we're always looking for students who want to do, have experience of survey research and experience of recruitment and have great part-time positions. So definitely reach out if that's something that anyone is interested in, or if you have other questions. Thank you, Elise.
So we'd like to invite any Zoomers who have a question to go ahead and unmute and ask their question. Any questions here? Allison. If I could just ask a quick follow-up to what you were saying, are those mostly quantitative surveys, or do you do qualitative work as well?
Thanks, great question. Yeah, so we also have a line of qualitative data collection, we do interviews, focus groups that take over work, and then we have a team of chart reviewers who do some of the qualitative chart review for EHR. And then part of our other line of work that's not capital R research is our evaluation science that Lauren and I work together on. And that allows for the opportunity for a lot of community organization collaboration. So there's a lot of opportunity there with some internal evaluations that we do for the health system.
Way to look at the chat.
So I'm on Zoom here and looking at the chat, and there's not much to tell you. We have a comment from one person saying, "Hi, Malini. It's great to hear about the new center and all the work happening." We have another person saying, "Thank you so much. Great presentation. Sorry I couldn't be in the room today." But no specific questions.
Well, I appreciate it. Thank you, everyone, and thank you again for the speakers. And it's so nice to see all the many faces that have come out from Health Partners. They travel in a big pack, and I love it. Being an extrovert and a team player, this is exactly the type of friendship we need. Dr. Jim Hart is here, and he very aptly described the Health Partners group as some of our friends in the community. So I'm so glad to see so many of our friends from the community here today. So if you could please do join me in thanking the speakers today.
If you have questions or if you wanna talk to any one of us in person, please look for us. We're in the page of HealthPartners Institute. You can find our emails there. Or some of them are here, but we are more.
Fantastic. Thank you so much. Zoomers, we'll see you next week. Wonderful, wonderful. Thank you.